Good afternoon. I'm Giovanni Veronesi from the University of Insubria in Varese, and I'd like to thank the organizer for the opportunity of presenting here today our work on workplace violence against healthcare workers in Northern Italy. We have no conflict of interest to disclose. As you all are aware of, workplace violence in the healthcare setting is a growing concern worldwide as well as in Europe, where about 50% of the workers reporting having been assaulted at least once over the past 12 months. These digits mostly come from retrospective studies subject to a substantial heterogeneity across each other. This is due to a number of factors, including selection bias, as most studies have been conducted on high-risk subpopulations, the lack of standardization of violence measure and definition, recall bias, as well as participation bias, as prevalence estimates get smaller and smaller as participation in the studies gets larger. And so, all considered, these are poorly informative to prevention. Conversely, surveillance based on prospective collection of incident report has the potential to overcome most of the drawbacks of retrospective studies. But at the same time, it is affected by underreporting, and its implementation is still scanty and spotty, mostly based on single center or hospital experience. In 2019, Lombardia region, the most inhabited region in Italy, promoted new guidelines for violence risk management based on risk assessment, root cause analysis, implementation of preventive and mitigation actions, and their monitoring over time. But how to make it work in real life is still an open question. Stemming from such a document, we developed the DEVO study with the aim to develop and implement a guideline-based protocol for violence risk management in two large referral public hospitals in the region. And here, we will report on underreporting before and after the implementation of the new protocol, which became effective since November 1st, 2021, as well as to estimate the 12-month prevalence by subgroups after 1 year since the implementation of the new standard. The standard that we design is based upon three main pillars. The first one is incident reporting. We design a form based on international standards for violence definition and attributes. The form was easily assessed, and the Risk Management Office was available to assist with the filling in. The workforce underwent periodic training on the topic. The second pillar is root cause analysis to assess perceived stressors, violence impact, and work constraints on the assaulted workers. It was made by a dedicated psychologist using again validated questionnaires and allowing a periodic reassessment of high-risk workers. The third pillar is a web-based data collection platform with customized assets by hospital and user, anonymization of personal data to comply with data protection legislation, at the same time allowing the identification of high-risk workers and gathering a secure access to the questionnaires to be filled in online. We define underreporting as the ratio between the observed and the expected number of violence episodes, where the expected were taken from literature, and if the number is less than 1, then it means underreporting. A 12-month prevalence was estimated on the number of workers in payroll archives at the beginning of each year. And in 2022, we were also able to disentangle the first violence from recurrences on the same worker. Now, in the historical period, trends in 12-month workplace violence prevalence were diverging in the two study hospitals. And of course, they were following opposite patterns in underreporting. And in the last available year, 2020, the underreporting was substantial, ranging from 50 to 70% into the two study hospitals. After the implementation of the new protocol, the prevalence rose in the two hospitals, being close to 2%, and the observed to expected ratio was now larger than 1, suggesting that we were fairly able to fill the previous gap. As I mentioned, the prevalence was around 2%, and 20% of the rate was due to recurrences on the same worker. Men were those at higher risk of aggression once the disproportionate number of women in the workforce has been taken into account. And also, we detected a decline risk by age, with the youngest being those at the highest risk of violence. Amongst the hospital wards, psychiatry and mental health departments, as well as the emergency departments, were those at the highest risk, and nurses were the job title most affected. And in all of them, recurrences were now close to 25% of the overall prevalence rate. Finally, we were able to describe a gender-specific violence pattern, with women more likely to be subject on treats than men. Visitors were involved in 30% of cases. 35% of women reported psychological consequences, and about 1 out of 5 were subject to life-threatening feeling during the aggression. And finally, the most prevalent recognized contributing factor was the sociocultural one, while it was the clinical, so related on the psychological condition of the aggressor when the assaulted worker was a man. Our protocol was developed according to international standards, so to enhance comparability, and it was implemented in at least 2 complex hospitals, so our experience can provide useful information for a large-scale implementation. The main limitation is based on short-term implementation, but the protocol is still in use, so we will be able to document long-term sustainability shortly. So to take home, an active involvement of the organization can substantially contrast violence underreporting, and we identified a few key factors from our experience, including the dedicated resources and tools, easiness of reporting, training, and feedback with worker safety representatives. And the accurate identification of more vulnerable workers can really better inform priorities and contents of preventive policies at both a local and at a large scale. More will come from current analysis on the role of organizational factors and perceived stress on violence prevalence and the impact. I wish to thank all the DEVOS study team, which is made by incredible people with a diverse background, all working together towards the same aim of documenting and possibly stopping violence. Thank you.